everybody doing with the probing and the scalars? Are you guys doing okay with that? You're in the explorers, your hand is starting to become a little more comfortable inside a mouth? Yes? No?
Yes, but it's a lot to kind of like, I don't know. I felt like the maneuvering and the rolling and rocking was like a little bit interesting.
That is going to become second nature to you. Now we have the task of, because with your assessment instruments, you had the opportunity to learn how to use a little bit of finger movement, which is our natural tendency to want to do that. Now we are bopping you on the head if we see any finger movement with the periodontal instruments for calculus removal and that type of thing. So it's relearning something that you're still learning, and it will become second nature. I was telling a group of students the other day that you are not going to become comfortable with this until the end of 142 or sometime during 143. It takes you that long of doing it before you really say, I think I've got it. I don't have to think about it anymore, and it's becoming second nature. And we realize that this is new technique and new habits, and our goal is just to make sure that you have the basics down so you can move on to the next instrument. Because as you found out with scalars, not much different as far as angulation and everything than with the curets. Your universal curets, except that the instrument is shaped a little bit differently and you're working subgingivally. And we're going to get into area specific curets next week, which is what we're going into. And again, the techniques are going to be very similar: choosing the proper working end, going in closed, opening it, calculus removal, that type of thing. So it just kind of tumbles into place. So when you're in clinic next time, hopefully you'll have all of your gray instruments sterilized. You have 2 anterior area specific curets, and then you have a gray, they're gray and gray orange, and then you've got a gray black and another gray with a lot of angles to it with a complex shank. So that's how you'll differentiate them. But gray for Gracey. Okay, Gracey was the doctor who invented these type of curets back in the 20s or something, a long time ago. So let's get into area specific.
Misty, real quick. Is there any way, it says that the chapter 20 PowerPoint is locked, and if you want to go over that later, is there a reason it's locked?
No, I have it pulled up.
The chapter 20 in Wilkins? I can.
Yeah. Okay. Well, I'll maybe repost it then.
Thanks.
Yeah, in the break, I'll repost. How's that? We'll take a break after this. Okay, so we've gone over scalars, which are for supragingival calculus. It's for enamel, not for root surface. We've gone over universal curets, which can be used in anterior and posterior teeth, but we're only showing you right now in the posterior because we don't want to confuse things. And it's shaped very differently as far as not having a point or a tip on it, and it's not triangular, it's semicircle with a toe. So that's meant for subgingival and root surface. Now, can you use a universal supragingivally? Yes, you can. If it fits, you can use it. But there are some limitations to the universal curet that you might need to expand your repertoire on by using something called area-specific curets. And an area-specific curet is a periodontal instrument used to remove light calculus deposits from the crowns and roots of the teeth. Now, your universal is for light to medium deposit. Area-specific curets were developed as, we used to call them finishing curets. You'd get all the big stuff off, And then you have the little stuff, and then you go in and you try and smooth. And that's what the area-specific curets were really developed for. But now they have these area-specific designs in all sorts of instruments. They have them in rigid, which is meant for heavier calculus than the finishing curets. But these curets have a long, complex functional shank, so it's got bends in them, and it's especially suited for instrumentation on the root surfaces. All right, you've got lots of bends, and we call this area here an elbow. All right. Like a universal curet, they have a rounded back and a rounded toe and a semicircle cross section. So this is really the exact blade of a universal curet. The only difference is this is at an angle. The face is at an angle. The cutting edges are curved. All right, so you've got curved cutting edges here. You've got a toe. Now, when you get into instrument sharpening, they're going to tell you that this is a straight design, not to confuse things, but it's not. But you can see where this area here is meant to hug around a tooth much more than this. And that's what that curve is for. So it makes an area specific very special and specialized, okay? It's the relationship of the face to the lower shank. That face is tilted in relation to the lower shank, and it causes one cutting edge to the lower one. All right, so even though this is a blade here and this is a blade here, the cutting edge is the lower blade. This is 70 degrees. What is the angle on a universal curet?
90 degrees.
90, yes. Why was there a question mark in whoever said that? 90 degrees, you know that. So that tilted face of an area specific is different than the design characteristics of the sickle scalers as well as the universals, because you can see that the sickle scaler is at 90 degrees, the universals at 90 degrees, and that area specific is tilted. And it only has one blade that you're going to use, and you're going to be using the lower blade. Only the lower cutting edge is used. Because the lower cutting edge is used, it's called the working cutting edge.
So Misty, I have a quick question. This might be a silly question. I was just wondering if only the lower edge is used, why are there two cutting edges?
Because that's how they make the instrument, for one. And number two, if you need to do curettage, what you're doing is you're flipping the instrument and you're using this blade to actually, instead of scaling the tooth and root surface, you're scraping against the gum tissue.
Oh, interesting. Okay, thank you.
Yeah, we used to do that a lot. It's not recommended much anymore, but especially when these instruments were designed, everybody was getting curettage. The thought was, if you remove the necrotic inflamed tissue, healthier tissue will come faster. And they're finding out histologically and other things that it's not really, it doesn't work that way.
Gotcha, okay.
So the cutting edge, okay, that's not being used is the non-working cutting edge. The nice thing with this is the non-working cutting edge is always angled away from the soft tissue. Remember, with your universal curet, you have to tilt the shank just a little bit, tilt the face towards the mesial and towards the distal. Otherwise, because it's at a 90 degree, you're going to be cutting into the gum tissue with that outer blade. And this automatically has that tilt for you. So it helps protect the tissue. So you don't need to tilt this. Just by placing the curette underneath the gum tissue with the terminal or lower shank being parallel to the tooth surface, you automatically have that cutting edge towards the tooth surface at that 70 degree. If the lower shank or terminal shank is parallel, you have correct angulation. So it takes a lot of the guessing out of it for you, and you've got great visual cues with your shank. So you want to know which end you're using. You want to know which end is the one that needs to be sharpened. So you need to be able to identify the lower cutting edge. It's easier on some instruments than it is on the other. I was doing an instrument sharpening course. I was in my mid-40s. I was doing a CE for my hygiene association, and that's when I realized I needed reading glasses because I was having problems with one of the instruments, an anterior instrument, to determine which was the cutting edge because they look so identical. So ladies and gentlemen, everybody's going to get to the age where you're going to need some sort of help. I thought I was immune, but no. So you want to hold the instrument so that you're looking directly at the toe. Okay, and that's what you're doing also with your all your other instruments. You're holding it so you're looking directly at the toe. Is it a triangular shaped instrument? Is it a semicircle? What is the angle of the blade to the lower shank? So you raise or lower the handle, okay, so that the shank is perpendicular to the floor. The terminal shank is perpendicular to the floor. And then this will be evident. One of the cutting edges is lower, which is closer to the floor, and that's your working cutting edge. The lower cutting edge is used for instrumentation. Only the lower cutting edge needs to be sharpened. So we've got these specialized instruments with lots of angles in the shank. They've got long, complex shanks to help reach harder to reach areas and root concavities and deeper pockets. And the face is tilted in relationship to the lower shank. And you only have one cutting edge. How many cutting edges are on scalars and universal curets? Two. Yes, two. There we go. All right, so let's take a look at some of our Graceys. We have a Gracey in your kit, 1516, and a Gracey 1718. When Graceys were first created, they were created when we were doing stand-up dentistry. This was even before my time. Stand-up dentistry, stand-up hygiene, and the patient was only tilted back to a 45-degree angle. So the angles that the instruments needed are very different from when the patient is put in a supine position and laid totally flat, right? So we started out with a Gracey 1-2, which is the straightest up and down. Then there's a 3-4, 5-6, 7-8, so it goes more posterior. The 7-8, 9-10, which kind of goes towards the premolar area. Then you have a posterior 11-12 and a 13-14. So the 11-12 is a mesial, the traditional mesial instrument. The 13-14 is a traditional distal instrument. But they now have a Gracey 1516 and 1718. So the higher the number, the more bends and elbows there are. So a 1-2 is going to be the straightest, and a 1718 is going to be the curviest. And we've got modified versions of these curets as well, so we can access things better. The 13-14 is your traditional distal instrument, but they have a hybrid called the 1718, which you will get in your second year kit. And then the Gracey 1112 is your traditional mesial instrument. There is a hybrid of that called the 1516. That is your gray-black in your instrument kit. You can get almost anywhere with that gray-black on a mesial surface of the tooth, and you can't on an 1112. So these were developed to gain better access to the posterior teeth. So this is a picture of an 1112 comparison. This is an 1112, Gracey 1112, which is a mesial instrument. And you can see this lower shank is parallel to the long axis of the tooth. And then we're going up and over. Look how closely you have to be fulcruming there versus if you had a longer shank with more curves, you've got a little more flexibility. If you needed to go 5 more millimeters down the root surface, this is going to allow you greater access than this. So the 1112 and 1516 are both mesial instruments. One just has more curves to it. When you are having your boards, sometimes they will say an 1112, sometimes they will say a 1516 to talk about which instrument would be the best to use. 1314 is a distal instrument, and you've got that's your gray-gray, so it's for the distal instrument. Now remember, your distal instruments just start at that distal line angle and go distally. That's all you use it for, all right? But look at that 1718. It's got this huge elbow. So think about a deep, deep pocket down here on the distal of number 30, or you're trying to get to that third molar area. That 1718 is going to reach anywhere. The 1314 might not. Now, do I have a 1718 in all of my kits? No, I do have a 1516 and a 1314 for my Gracey sets. 1718, I've got 1 or 2 in a bag separately in case I need them. And you'll learn when you're in private practice what instruments you like the best. So, because if you've got a dozen instruments in your kit, you have to sharpen all of them and maintain them. So you end up weeding out. For the maxillary, short shank versus long shank. This 1718 can be adapted to the mesial of an instrument as well, or mesial of a tooth as well. The longer the shank, the farther you can reach, and the deeper the pocket that you can reach. So the original Gracey series contained 14 curets, starting from number 1 and going up to 1314. And a set of 3 or 4 Gracey instruments are usually adequate for the entire dentition. But over the years, modifications have been made to the standard Gracey designs. So they have rigid shanks for heavier calculus. They have extended lower shanks. They're called after 5s for the deeper pockets. They have miniature working ends and micro miniature working ends. So the blade is very tiny, so you can get into long, narrow pockets. Do you need all of them on your tray? No, but it's nice to have the option in case you do need them. So let's take a look at area-specific curets on anterior teeth. You want to choose the correct working end. Right, so there's a number of ways you can do this. One is the visual cue. You place the instrument next to the tooth, and the face should tilt towards the tooth, not towards the gum tissue. So the face should be partially hidden because it's angled. Can you see that you can see the whole face here? This is the lower cutting edge. If you went subgingivally with this, that cutting edge would be around the tissue. Is it tilting towards the tooth? Or is it tilting away from the gum tissue, away from the tooth. Memory aid for anterior teeth. Face tilts slightly toward the anterior tooth. I don't know why they consider this a memory aid. It doesn't work for me. So you've got two lower cutting edges because you have two ends of the instrument and they're mirror designs. This is a Gracey 3-4. So this would be the 3 side and this would be the 4 side. Now remember, it starts with a 1, 2, 3, 4, 5, 6, 7, 8, and goes all the way up to 17, 18. So there's a number of them around now. Me, my patient, my light, my mirror, my grasp, my finger rest, my adaptation. So you have surfaces towards you and surfaces away from you. And this requires you to flip your instrument. If you're doing one end for the surfaces towards, you have to flip it to use the mirror end, other side, to do the surfaces away from you. So to select the proper working end, okay, once you've got that, you're going to start in that get ready zone, which is supragingival. You place the working end at the get ready zone. The toe aims towards the distal surface. You're always going in the direction your instrument is moving. You insert the face, hugging the tooth. You adapt the toe third. You lock that toe third against the root surface. So you're opening up that angle just a little bit. You're adapting that toe third. You're working across the facial. All right, so you're coming across the facial to the other side of the tooth. So you can see that this instrument is angled towards the tooth. You roll the instrument as you approach the distal facial line angle to maintain adaptation. Look at this. If you don't start rolling the instrument before the line angle, look, it's going to come off the tooth and poke the tissue. So you want to roll that handle before the line angle, and then you continue rolling it until you work at least halfway across. And the nice thing with area specific, this should be completely parallel to the long axis of the tooth. So you'll be doing, if you're doing an entire sextant, facial and lingual, you'll be sitting in the 9 o'clock position, doing the surfaces towards you on the facial, and then the surfaces towards you on the lingual, and then you switch over to the 9 o'clock or the 12 o'clock position to do the surfaces away from you on the facial and then the lingual. That way you're not flipping and having to move your chair and everything else. So that would be the ideal sequence. So you're going to select the correct working end. So the face should be tilted towards the tooth surface. Remember, there's only one cutting edge. So for the posterior teeth, it's the same thing. Same thing, you got to figure out which is the cutting edge. The lower shank, you're going to get that parallel between two teeth. You just stick it between two teeth like you do with your other instruments that you've done. Does that functional shank go up and over, or does it go down and around? It's very evident with these larger instruments. Not so much with the Explorer, but boy, once you get into your 204, your posterior sickle, and your Barnhart, and now your area specific, it really shows. Posterior equals parallel. That functional shank is up and over. So guess what? There's nothing new here. The traditional pairings are a Gracey 11-12 for your mesial and your Gracey 13-14 for your distal. That's traditional. but you have double-ended instruments because they're needed. You need to be able to, what you use on the maxillary right buckle is the same lingual, and then you need to switch the instrument to do the other surfaces. So they have different combinations of these instruments as well, and we've tried using the other combinations, and it's not what we see in private practice, so we went back to the traditional. Remember we said an 11-12? Now there's got an 11-15 or a 12-16 or a 13-17 or 14-18. You don't see those in private practice. So we're not going to have them. They're good, but if you learn this way, then it's harder to adapt. So application of cutting edges. Think about your scaler, your posterior scaler. Think about your universal curette. Think about your ODU Explorer. There is nothing different in this picture. Nothing. You start at the distal line angle and move distally. And instead of just taking the instrument out and using the other side of the blade, the inner and the outer, you need a different instrument though to do the rest of the tooth. So this would be your 13-14 instrument. And then you'd have your 11-12 or 15-16. 13-14, 11-12, 13-14, 11-12, 13-14, 11-12. So if you were scaling this, you would have your 13-14 in your hand because you always start with the distal and you always start in the most posterior surface. So what you do is you'd have your posterior curette here and you'd go 13-14, 13-14, 13-14, 13-14. You put that instrument down, you pick up your mesial instrument, 11-12 or 15-16, and then you do the rest of the tooth surface. All right, so you're keeping that one instrument in your hand as long as you can to maximize time and effort. So you're not putting an instrument down and picking another one up for each surface of the tooth. So traditional pairing, Gracey 11-12 and a Gracey 13-14. So the 13-14, you're going to use the 14 end. You do not need to memorize that it's the 14 end on the mandibular right posterior. It complicates your life if you do that. You just want to take a look at the instrument. You need to be able to be aware that by how these instruments are labeled that this is the 14 end, but you're never going to be asked which end of the instrument is used for such and such, okay? You're expected to be able to use your critical thinking skills to place it in the mouth to determine the proper working end. So you're going to pick up the instrument and use the 13-14 first, and you do distal, 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 distal. You put that instrument down, you pick up the Gracey 11-12, and for this it's the 11 side, and you do the rest of the tooth surface, starting in the most posterior, working anteriorly. And you do the same thing on the lingual surface. So you'd use the Gracey 13 to do the distals on all the linguals, and then you'd put that instrument down, pick up your 11-12 again, and then do all the mesials. Now, if you're doing the entire quadrant, and you know you're doing the entire quadrant or sextant, do we do just the facials and then do just the linguals? No, we will do the distal from facial and lingual for the entire sextant. Put that instrument down, then we'll pick up our mesial instrument and do all the mesials from the posterior sextant forward and do both buccal and lingual that way. In school, you are dividing things up much smaller. Sometimes you're only going to be scaling 1 or 2 teeth before you're allowed to go on to a new area, depending on how the patient is. So they've got modified pairing. Look at this, an 11-14, 12-13. So instead of having an 11-12 and 13-14, they've paired them this way, which will allow you to use the 11 and the 14. Okay, so the 14, you're going to be doing the distals on the entire sextant. You flip the instrument, and then you can do with that same instrument, go around and do the mesials. Same thing with the 12, 13. So you only need one instrument for the facial and one instrument for the lingual. You're not putting it down and picking it up for a mesial and distal. Same instrument, all you're doing is flipping it. This is the one that, that we tried for a couple of years, and it was just too confusing for everybody. The instructors and the students, when they graduated, they had not seen 11, 12, 13, 14, that type of thing. So our goal is to have you comfortable when you get done with us and you have your license, that you can adapt to any environment that you get into. So we try and find things and instruments that you're going to be exposed to most often. So the advantages of doing something with a modified pairing is that you can do the entire aspect of a sextant can be completed without needing to change your instruments. So we're going to be getting in with an area specific: me, my patient, my light, my mirror, my grasp, my finger rest, my adaptation. For the distal surfaces, you have your gray in your kit, which is your 13, 14. In your second year kit, you'll be introduced to the 17, 18. So you complete the distal surface first with an area specific curette, distal line angle going distally. The sequence is the same. Get ready zone, you're going to be placing the handle towards the gum tissue. All right, you want to introduce that toe underneath the tissue and go in the direction that the toe is facing. You lower the instrument handle, all right? So you're lowering the handle, and what that's doing is closing that angle next to the tooth. You're hugging the face against the tooth. You insert beneath the gingival margin. So if you can imagine what this is looking like underneath the gum tissue, you don't want an opened angle and just shoved down there. You want it next to the tooth. So you've got to lower the handle, introduce the toe, insert it beneath the tissue. And if this is a technique check, if the lower shank is parallel to the tooth surface, then that face to tooth surface angulation is automatically going to be at that 70 degrees. This is not an instrument where you tilt towards the mesial and tilt towards the distal. Area specific, you want completely parallel. We call them self-angulating. So it's easier to begin with the posterior most tooth and move forward. So you do all the distals that you're going to be doing because you've got that instrument in your hand. So when you're done with the distals on the teeth you're going to work at, you're going to put that instrument down and pick up your Gracey. With you, it's going to be a 15, 16, but do know that an 11, 12 is a mesial instrument as well. And with that, you start at the distal line angle and do the rest of the tooth all the way forward. Get ready zone, the toe is aiming towards the mesial surface. Look at how this handle is coming down a little bit. You want to introduce this toe underneath the gingiva. So you're going to introduce it underneath the gingiva, and then you're going to stand up on your fulcrum to upright the instrument, and then you'll be in the proper working angle. Lower the instrument handle to insert it underneath the tissue. Then you raise the lower shank, you're raising the handle, and you're making your strokes. And again, you want to roll the handle as you approach the mesiofacial or the line angle, because you want to start rolling it before you get to that line angle. Think about your Explorer. If you wait until you're at the line angle, you're poking into the gum tissue. Same thing's going to happen with your instruments, all your other instruments. walk, 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 okay, and you work your way halfway across the mesial surface. Because when you come along the lingual, you're going to work your way at the other half of the mesial surface. Terminal lower shank is parallel to the long axis of the tooth. For the maxillary, the bottom teeth, mandibular teeth, are usually much easier to access than the maxillary teeth. You want to follow the same sequence used for the mandibular posterior by selecting the proper working end. So you turn the toe towards the distal surface, okay? You establish that 0-degree angulation. Now look at this shank, it's around the tooth, but this is the correct working end. The handle is towards the gum tissue. On the bottom teeth, on the mandibular teeth, the handle was down towards the gums. For this, the handle is up towards the gums, and that makes that face of the blade hug the tooth. And then once you are under there, you bring the handle up into proper angulation, so you can see that you're parallel to the long axis of the tooth, and that face to blade is going to be at that 70-degree angle. So for your mesial instrument, you start on the distofacial, for here, the distofacial line angle, and you're going to work your way all the way around the facial surface. You want to be rolling that handle before you reach the line angle. And you should end up completely parallel to the long axis of the tooth. The lower shank is parallel to the distal. The functional shank goes up and over. And that is area-specific curets. Are there any questions? I'm taking that as a no. Okay, let me stop the recording here. I'm going to upload what you need in Canvas